This is going to be a review for respiratory medications. So first I'll let's go through some of the basics, some of the general information. So in review, cholinergic versus anticholinergic. Cholinergic is going to be your rest and digest system. With this, you're going to generally have more mucus production, increased urination, increased GI activity. And so when we're talking about the anti-sludge sludge pneumatic, with cholinergic, we want to generally think we want to stop this with respiratory medications. Because respiratory, we do not want them to have increased mucus production. We want to decrease the mucus production to help open up our airway. Whereas anticholinergic is your fight or flight response, which if you want to be able to fight or run away, you're going to want to have more oxygenation. So to do that, you're going to bronchodilate your lungs to help get more air in. So anticholinergic, your anti-sludge, is going to help basically bronchodilate your lungs, decrease your mucus, where cholinergic will potentially increase the mucus production and then lead to bronchospasms. When it comes to receptors, you want to be aware we're going to talk about beta stimulants in this portion, generally beta 2 stimulants, but we're also going to see some activation of beta 1. So, what are those receptors? So, beta 1 is going to be primarily your heart. Okay, it's going to increase your heart rate, which then increase your blood pressure, increase your cardiovascular system. Beta 2 primarily works on your lungs to lead to bronchodilation, but it can also affect your liver and increase the glycogenolysis, basically to break down glycogen into glucose as well. So if we were talking about these, generally speaking, you're going to have options of affecting both beta 1 and beta 2, so you want to be aware of both of those. So one, remember, was the heart, 2 is lungs and the liver. Asthma versus COPD, generally speaking, they're going to be the same, oversimplified, but the same thing. Okay, asthma happens acutely and is reversible. COPD happens chronically, and we control the symptoms. When I say that they're causing the same thing, they're both going to lead to bronchoconstriction, bronchospasms, increased mucus, decreased airway clearance, and issues like that. Okay, so we're generally going to treat them with some of the same medications to help open up the airway. First up is going to be our short-acting beta 2 adrenergic agonists, or beta 2 stimulants. This is going to be albuterol. Albuterol is going to be your only rescue inhaler. Any other terol is not going to be a rescue inhaler. It's going to be help to confer control of the symptoms. So no matter what, they're going to stimulate the beta 2 receptors, as I said, stimulate your lungs to bronchodilation. By stimulating your lungs to bronchodilation, you open them up and help just increase your airway, increase your oxygenation, get more gas exchange. Albuterol is going to work quickly. It's also going to have a shorter duration of action. The other terols, because albuterol is the fastest one, the other terols are going to be longer acting. They're not going to work as quickly, but it's going to have a longer effect in the control standpoint. So what do you want to be aware of? Well, it's also going to lead to affecting beta 1. Affecting beta 1 is going to lead to tachycardia, hypertension, palpitations, angina, avoiding his patients with history of hypertension, angina, MI, and any sort of cardiac history. It's also going to lead to headache because when you're increasing your blood pressure, you're going to increase the pressure vessels in the head itself, leading to a headache. But also, it's kind of acts like a CNS stimulant, so it can lead to some insomnia, nervousness, muscle tremors from the excitation of the beta 2 receptors, your sympathetic nervous system, a little bit. So, on top of that, we also want to be aware, obviously enough, did it actually help the problem? Did it bronchodilate the lungs? Did the oxygenation get better? Did the respiration rates go down? What were the problems? We want to be, I can't stress again that, albuterol is the only one that's worked for rescue inhalation. The other terol, salmeterol, formoterol, um, ephemerol, those are all going to be control. Same complications, same things you want to assess for, same things you want to avoid. It's just acute versus control. Inhaled anticholinergics. This is also a bronchodilator. So these all end in tropium. Okay. When it comes to inhaled anticholinergics, you want to be aware of that. You're going to look for anticholinergic complications. Your anti-sludge, anti-salivation, lacrimation, urination, diaphoresis, GI activity, and then emesis. So we're slowing down the GI tract, we're slowing down urination. We want to make sure we're assessing for glaucoma, assess for urinary retention. But we're giving this to ideally give them the bronchodilation to help increase their ability to breathe and oxygenate and perfuse gas better. The other thing you always remember with anticholinergics is always want to assess for glaucoma because it can increase the intraocular pressure in the eyes, which is basically what glaucoma is. Other things you want to be aware of is you want to caution if they have any allergies. Of course, any allergy or any medication, that just goes without saying for any medication. But for this, you want to be aware if they have any allergic reactions to soy and peanut allergies. Soy and peanut allergies are going to be used in the propellant of the inhaler itself, so you want to be aware of that. Since these are the first two inhalers we talked about, we'll take a little pause. So any inhaler, you're going to want to rinse and spit. If you don't rinse and spit, there's a risk that you can affect the local biofilm and leading to fungal infection in the mouth. This will be more common with your inhaled glucocorticoids, but any inhalers you want to swish and spit. If you are giving two inhalers, give the bronchodilator first, then the anti-inflammatory second. If you have two puffs of the same medication, you're going to want to wait 30 seconds to a minute between each puff of the same medication, 5 minutes between each new medication. All right. Methylvancines, theophylline. This one basically acts as a bronchodilator, but it works through kind of the CNS, activating sympathetic nervous system. It acts as basically a CNS stimulant. Okay, so we're going to want to know for this one that we avoid any other CNS stimulant. So through a CNS stimulation, what do you get? You get bronchodilation. Other than that, you're also going to have the excitation of your cardiovascular system, the hypertension, tachycardia, dysrhythmias, angina, palpitations, MI. You want to avoid for any cardiac history. You want to avoid any history of seizures of epilepsy because the CNS stimulant can increase the risk of seizures. You want to make sure you give it in the morning, not at night, because it can lead to insomnia. We want to make sure we not double up the dose. It's a very narrow therapeutic range. So if you have narrow therapeutic range, basically, take the same time every day. Do not double up. And just look out for the signs of toxicity, which would be generally the seizures, dysrhythmias, tachycardia, extreme hypertension, so on and so forth. So you want to now avoid any other medication that's going to lead to an increase in our CNS stimulation at all. And one of the biggest things is going to be basically assessing for the caffeine intake. Caution in any sort of peptic ulcers or GERD, because it can lead to some GI complications and lead to increased risk of GI bleeding. So we want to avoid that. We want to just assess the liver kidney failure levels. Make sure can they handle this medication that can become toxic very easily. Not that it's going to directly affect your liver kidney levels, but if they're already impaired, it's going to lead to increased risk of complication. So that was the end of the bronchodilators. From here on out, it's going to be the next three are going to be the anti-inflammatories. These we would give second. So glucocorticoids, we've covered these quite often. They're used for a lot of various things, so they're great anti-inflammatories. They work with anti-inflammation by suppressing the bone marrow, suppressing white blood cells, In doing so, we have the bone marrow suppression, which is going to lead to the increased risk of infection, which is why we really make sure we rinse and spit after we give these um, as an inhaled medication. We want to be aware it can lead to anemia, where it can decrease your platelets, increase risk of bleeding for any sort of bleeding. So I want to avoid any other medication that can increase risk of bleeding with it. You have osteoporosis. It's going to pull the calcium out of the bones. So make sure you're increasing the calcium intake and vitamin D intake. You want to assess your renal function. With your renal function, you're going to want to also assess sodium levels, because sodium is going to be retained, leading to edema, hypertension, fluid volume overload, and weight gain. And with the retention of sodium, we end up losing potassium, leading to hypokalemia. And also, it's going to help. It's going to not help. It's going to increase retention of glucose, leading to hyperglycemia. So you want to caution anyone with kidney failure, diabetes mellitus, on any sort of medication increased risk of bleeding. Avoid live vaccinations, large crowds, sick people, things like that. And then also with the, okay, remember with the hypernatremia, it's also going to lead to an increased risk of your blood pressure. So avoid in cardiac history as well. So if we're taking it as an inhaler, generally inhaled medication is going to have more localized effects, less risk of systemic complications, but the systemic complications are still there, just not as elevated if you were to take an oral or IV titration. If you're taking a nasal glucocorticoid, the localized effects are really, really decreased to chances of having systemic complications with nasal spray. It's generally going to be more just localized to the nares itself. And if you're doing that, you make sure you're blowing your nose before you take the medication, and you swap off nares every other administration. Mast cell stabilizers, cromolyn. This one you want to be aware it's going to have to be given 2 to 4 times a day. Generally, it's going to be safer for children. It's going to just basically kind of suppress the inflammatory process of with the mast cells to help with some localized bronchodilation. Bronchodilation from the anti-inflammatory properties. So it gives you bronchodilation through being anti-inflammatory. So I make sure we're clear what I'm saying there. That's how you're opening up the airway. So with this, it's going to help good for exercise-induced asthma, short-term control things. It's not going to be an acute rescue medication. We can help prevent things from swelling. If we give this for someone with exercise-induced asthma, we're going to give it 15 minutes beforehand. We're going to make sure it is not for anyone with who's actually having asthma attacks, asthmaticus. Otherwise, just kind of caution your liver and kidney failure should be fine. Montemicalast. So for this, we're going to want to make sure we are assessing again. It is for control, not for acute exacerbation. We can give this to someone 2 hours before they're going to do exercise for exercise-induced asthma. It does not be given as often, but we do want to make sure we are assessing now for liver toxicity, so assess your ALT and AST. Otherwise, should be fairly common. Again, it's both cromolyn, montemicalast are going to be for prevention control versus acute rescue that would only be albuterol. So going on to the upper airway, we have our antihistamines. So diphenylhydramine, which is our sedating antihistamine, so it works on the CNS a little bit. And then the sertrazine, which is our non-sedating antihistamine. So they both are going to have fairly quick onsets of action, but the durations are going to be different, and then the sedating effects. Diphenylhydramine, short duration, 4 to 6 hours, but it can lead to CNS sedation. So you want to be aware you're avoiding any other CNS sedative, CNS depressant. You want to be aware this is going to be for allergic reactions, obviously, because it's antihistamine. So you want to make sure you're assessing the reaction they're having, assessing it afterwards. You're also going to want to be aware that you're going to look out for anticholinergic complications. So look for the urinary retention, the dried up mucus, and just the risk of glaucoma with this. The Sertraline, the non-sedating, has less risk of CNS depression, has less risk of anticholinergic effects, but they're still there. And then this one's going to last generally around 24 hours. But again, the onset is going to predominantly be about the same amount of time. Generally, you don't want to give them to children because you don't want to anticholinergic affect the children. Also, with CNS depression, this can lead to issues. That being said, if you have an allergic reaction, you can use it. It's just NCLEX versus real world. Some pathomimetics, they're going to mimic the sympathetic nervous system. They are going to basically lead to vasoconstriction, leading to decongestion of nasal passages to help increase the blood flow, help decrease the airflow, and help decrease nasal drip by decreasing not only congestion but also decreasing the blood flow to the nose, which then lead you to dripping out less fluid. And so with these, it says it's vasoconstricted, so decongested. And so if you're giving these, you want to make sure, can the patient handle excessive vasoconstriction? Is it going to be a risk to the cardiovascular system? We only want to use it for 3 to 5 days. 3 to 5 days, because more than that can lead to rebound congestion. It's going to be a CNS stimulant. So you want to make sure we avoid other CNS stimulants, other medications that lead to an increased risk of tachycardia, hypertension, and assess their airway, assess the blood pressure, make sure everything is going well. Antitussives. So codeine, dextromethorphan, these are all going to suppress the cough receptors in the brain. Okay. Before we give antitussive, we want to make sure we assess the cough. Is it a productive cough? It's a productive cough. We do not want to suppress it. We do not want to suppress a productive cough. We want them to be able to clear their airway. If they cannot clear their airway, there's a risk of aspiration pneumonia, which is going to then lead to worsening problems. This kind of mucus pool in the lungs, making things worse. So with codeine, we're generally going to still want to assess the respiratory function. Do they have severe asthma, COPD, sleep apnea, that suppressing the respiratory function, restoring the cough, can lead to worsening problems? Okay. We also want to make sure we avoid giving any other CNS depressant and any other opioid as well, will just exacerbate those problems. White penicillin. This is going to be mucolytic, so this one is going to help thin and kind of increase the mucus production. So now we want to know, can the patient handle the excess secretions? Do they have a good cough reflex? Can they clear out their airway? If not, it's going to now be a problem for aspiration pneumonia again, because we're not increasing the mucus. They can't clear it. They're going to drown the secretions. It's not going to be good. So with this, we want to make sure we increase the fluids to help. You have to have the fluid to thin out the secretions. It's also going to lead to increased platelet inhibition, which can lead to increased risk of bleeding. So we want to make sure we don't give it with any other. Don't give it with any other medication that's going to increase risk of bleeding. Mucolytic acetylcysteine, fairly the same as expectorant. Just want to make sure we increase the fluids. It's going to thin out secretions, increase the secretions. Can they have a good cough? Can they handle the excess secretions? Can they clear out their airway? It's also going to be, again, used for acetaminophen overdose. So you want to make sure we give this properly if someone has an overdose to help protect the liver. It's always good to be liver protectant if you're not sure. And lastly, the use of spacers. Spacers should be used with any inhaler. It helps basically disperse the medication when it comes out of a highly pressurized inhaler in the spacer, so they can breathe it out and actually get slow, deep breath deeper down into their lungs. Help increase surface area, the area the medication has been affected. Overall, better administration, better use, and that concludes the respiratory review.